The indications of partial aneuploidectomy are quite diverse, ranging from rhegmatogenous detachment, PDR, pediatric retinopathies as ROP, persistent hyperplastic primary vitreous or fever, dislocated lens material, as my colleague Felipe just mentioned, and IOLs, vitreoretinal interface disorders, and endophthalmitis. Trauma, blunt, penetrating, perforating, or intraocular foreign bodies are also managed by vitrectomy, and other uncommon indications as dense synthesis or asteroid hyalosis, uveitis complications, endoresection of melanomas and tumors, biopsy for intraocular tumors. Now, what are the indications of vitrectomy for primary retinal detachment? First of all, if we have a large and posterior retinal break. Why vitrectomy? In these cases, it may be inaccessible to reach the break. You may have to do excess cryo, as in this break we see in the video, and also sometimes impossible to buckle. Undetected retinal breaks is another indication for vitrectomy, simply because using scleral indentation and the modern visualization techniques, you can detect retinal breaks that are not visible by the indirect ophthalmoscope, as in this case. Macular hole and retinal detachment is an absolute indication for vitrectomy, and in these cases we do ILM peeling and closure of the hole, and also you have to search for a peripheral break as well, which may coincide with the macular hole. Giant retinal breaks is an absolute indication for vitrectomy, and actually PFC has revolutionized treatment in these cases. In such cases, you have to do at the end of surgery a direct PFC oil exchange and not fluid air exchange to avoid slippage of the retina. Multiple retinal breaks in different quadrants are also requiring excess buckling material, which may distort the globe, and in such cases, vitrectomy is the solution. Pseudophakic and aphakic retinal detachment, as there is no risk of cataract in these cases post-operatively, and there is better visualization through the lens and a PCO and after cataract. If you have a hypotony syndrome, retinal detachment and choroidal detachment, the success rate of scleral buckling ranges from 34 to 56%, which is quite low. Cryo causes a more breakdown of the blood-ocular barrier with more incidence of PVR. Very difficult to buckle due to the choroidal detachment, and drainage is difficult and commonly associated with complications. Upper bullous retinal detachment is another indication due to difficult cryo, difficult localization. A high buckle has to be done in order to close the break, and the DACE technique is definitely less controllable than vitrectomy. This technique is the drainage air cryo explant technique, in which we change the sequence of surgery. Of course, if you have PVR and epiretinal membranes, the best way to relieve traction is internally by removing the epiretinal membranes, as in these videos, and flatten the retina. And in such cases, of course, vitrectomy is the treatment of choice. Coexistent media opacities, as cataract or vitreous hemorrhage, or even patients with corneal opacities and detachments, can be managed with a temporary keratoprothesis, which allows visualization and all vitreoretinal work to be done. And at the end of surgery, you can put a clear graft again and restore clear media. Now, what are the key steps for vitrectomy for retinal detachment? First of all, how to select your gauge. Either you have, commonly we have in our practice the 23 or 25 gauge, and whichever you feel more comfortable. But whatever the gauge you are going to use, you have to be prepared with a full armamentarium of instruments. You have to be having the forceps, the scissor, the scraper, everything, and diathermy. Where to place your sclerotomies? Again, you have to think before you start surgery. If you have an upper retinal pathology, it is best to place your sclerotomies more towards the horizontal meridian so that you can reach the upper retina more easily. But if you have a lower retinal pathology, go more towards the vertical meridian so that you have a better access to the inferior retina. The first step is to do a core vitrectomy, and this step has two main aims. First of all, remove axial opacities, and the second is to create a fluid space in the central vitreous where you can move your instruments quite easily without entangling vitreous in the instruments and causing more traction. In such cases, the settings are 23 gauge using a 5,000 cut per seconds and a predominantly open port. The very important and critical step is the posterior vitreous detachment in cases of rhegmatogenous detachment. And this step is tricky because you have to look for vitreoschisis, which is a layer of vitreous adherent to the retinal surface, and you have to look for it and remove it. Otherwise, you will be confronted with postoperative failure and recurrence with PVR. And in such cases, in my hands, I use the Tano scraper, as you can see, to open just an opening in the posterior hyaloid and then elevate it using the Tano scraper and engage it with the cutter and continue. Where to stop with the PVD? At the posterior insertion of the vitreous base, as you can see in this video. If you try to pull further the hyaloid anteriorly, you will create iatrogenic breaks and it will be a more complicated situation. Next, after you remove the posterior hyaloid, you inject PFC to stabilize the posterior retina. You inject the PFC slowly and keep the tip of the needle inside the bubble so as not to have fish eggs. Do not inject PFC if you have residual traction on posterior breaks, otherwise you will get subretinal PFC. Then you go to shaving of the vitreous base, which is an essential step in all cases of detachment and vitrectomy, and it increases the success rate and lowers the recurrence. And this step is done by scleral indentation, and it causes less iatrogenic breaks if you lower the intraocular pressure and use indentation as well. Next, you complete your PFC fill, and while completing the PFC fill, you drain the peripheral anterior fluid through an anterior break or a retinotomy, and then you do endolaser to all retina breaks. Sometimes we do a 360 degrees endolaser in high-risk cases with extensive peripheral degenerations, but in these cases, avoid the horizontal meridians so that you don't injure the long posterior ciliary nerves, which will affect the pupillary reaction postoperatively. Finally, you do a complete PFC air exchange, and the residual anterior fluid may trickle posteriorly if you leave anterior fluid and cause macular fold. So you have to be cautious in this step. And finally, your choice of tamponade, either gas, air, SF6 or C2F6 in simple cases with 1 or 2 breaks, and patients who do not need to fly. In more complicated cases, silicone oil is the tamponade of choice. And one last point in this retinal detachment topic is the ILM peeling. When to do ILM peeling in high-risk cases, PVR, multiple breaks, giant breaks, hypotony syndrome, excessive RPE dispersion, associated hemorrhage, recurrent cases, and some surgeons do it routinely in all cases. Peeling the ILM ensures complete removal of the posterior hyaloid and any epiretinal membranes in the posterior pole and prevents recurrent proliferation in the macular area, as there is no scaffold for the cells to proliferate on the macula. Now, the next important indication is diabetic vitrectomy. By the way, I have 15 minutes, not 9, because they started the counter wrong. So diabetic vitrectomy is the second most important common indication, and actually our aim in diabetic vitrectomy is as follows: restoration of normal anatomy, clearing media opacities, relieving traction and achieving retinal reposition, and finally regression of PDR and a long-term stable status by doing a proper PRP. The first indication is diabetic vitreous hemorrhage, which is by far the most common cause of vitreous hemorrhage. Untreated vitreous hemorrhage may resolve spontaneously in many cases, but in others, it may be complicated by rebleeding, traction detachment, or ghost cell glaucoma. What are the indications of the indicators for early surgical intervention in presence of vitreous hemorrhage? Rubiosis iridis, no previous PRP, ghost cell glaucoma, and juvenile diabetics, type 1 diabetics. And during observation, you have to monitor the retina by ultrasonography to ensure that there is no detachment, and at the same time measure the IOP for ghost cell glaucoma. However, not all vitreous hemorrhage cases are straightforward because they may be masking underlying proliferations, as in this case. After you remove the hemorrhage, you deal with the proliferations by cutting them with the cutter into separate parts, and then use the bimanual technique to clean the retinal surface and leave the retina clean at the end of the procedure. Then subhyaloid hemorrhage is an indication for early vitrectomy. In my hands, I believe that interfering early in these cases preserves vision because the posterior hyaloid is pathological, and the best area to open the posterior hyaloid in these cases is exactly over the area of the hemorrhage because it gets you into the proper plane of dissection. and you can continue the section, and you see the hyaloid was quite pathological and white in this case. Traction detachment, one of the most challenging situations, and the indication for surgery in traction detachment is a traction detachment either involving the macula or threatening the macula. Extramacular detachments may remain stationary for years. In cases with extensive proliferations and traction detachments, the key is to get into the proper plane of dissection from the start, whether you do it with the probe unimanually or bimanually, and you relieve all traction on the retinal surface, leaving a clean retinal surface and achieving reposition. Some cases are complicated by combined traction rhigmatogenous detachment when a hole develops in the retina, and here the configuration of the detachment changes from concave to convex, and the bimanual technique is very useful in these cases. Our aim in combined traction rhigmatogenous detachment is to identify the hole, release all traction, and at the end of the procedure you do ILM peeling to prevent recurrent proliferation on the retinal surface. The next indication is vitreoretinal interface disorders, and macular holes, whether idiopathic, traumatic, myopic, or others, have one treatment, which is vitrectomy, and this is the only proven treatment. In such cases, you can remove the ILM if the hole is small, or in other cases, you can also do the inverted flap technique, as our colleagues will show in a while, in which you use the ILM flap as a scaffold to promote proliferation and closure of the hole. Vitreomacular traction syndromes can be cured simply by posterior vitreous detachment. If you achieve a posterior vitreous detachment, it will cure the case. Sometimes we combine it with ILM peeling in order to enhance resolution of the chronic tractional effects on the macula. Again, epimacular membranes have only one treatment, which is the macular pucker. They have only the treatment for vitrectomy with removal of membrane with and without ILM peeling, and the membrane can be removed in one layer with the ILM in some cases. Dropped IOLs and lens fragments, and dropped IOLs can be removed and sometimes repositioned in place, as you can see, using the scleral tunnel technique if it's a three-piece lens, and you put the haptics in the sclera and achieve visual rehabilitation at the time of vitrectomy using the same lens or even exchanging the lens. Pediatric vitrectomy is also an important indication, and it's different that you place your sclerotomies only 1.5 millimeter from the limbus. There is no place for posterior vitreous detachment in such cases, otherwise you will create breaks, and an iatrogenic break in these cases means failure. At the end of surgery, you do not achieve retinal reposition, but you leave the retina to reposit spontaneously after relief of traction, and it may take 4 to 8 weeks. Also persistent hyperplastic primary vitreous, in this case with a persistent tunica vasculosa lentis. After removing the lens, you cauterize the stalk, and then you excise the stalk to release traction on the retinal surface, taking care not to injure the retina. One important indication is endophthalmitis, whether bacterial or fungal, and the earlier the intervention, the better your visual result. This is a case of fungal endophthalmitis, and you can see the subretinal fungal colonies. Do not insist on PVD in such cases because you may induce iatrogenic breaks in an inflamed friable retina, and the aim is to achieve clear media, remove toxins and bacteria, and deliver antibiotics. Finally, vitrectomy has a wide range of indications with different scenarios for each case in particular. No case is similar to another. You have to be creative and you have to be prepared. Finally, I would like to invite you all to the Egyptian Vitreoretinal Society International Meeting in April. It's going to be in the historic city of Luxor. We promise you a very rich program socially and scientifically, and you are all welcome to register and attend. Thank you very much.